It's 2 o'clock. I'm Olive Martini, and you have just landed on the Working on Wellness Radio Forum. And my guest today is Dr. Maximilian Psolka. He specializes in cornea, contact, glaucoma, and refractive surgery. He's a retired U.S. Army colonel. Dr. Psolka served as a flight surgeon while stationed in Europe. He completed his Ophthalmology Residency at Walter Reed Army Hospital before completing a Cornea and Refractive Surgery Fellowship at Johns Hopkins Institute. Before joining Northwest Eye Surgeons, he served as Chief of Ophthalmology and Refractive Surgery at Keller Army Community Hospital in West Point, New York, and at Darnall Army Center in Fort Hood, Texas. He's a board-certified ophthalmologist by the American Academy of Ophthalmology. Welcome, Dr. Psolka.
Oh, welcome. Thank you.
Okay, well, you've got quite a resume there. Let's jump right in.
Sounds like a plan.
What inspired you to specialize in cataract surgery?
Well, after a long journey to finally become an ophthalmologist and years of doing work there, I found that I was more stimulated by the surgical side of the field than the medical side. And I think it's mainly because of my restless nature, and I'm a fairly impatient person. I might look somewhat composed, but I do think I can fool people. So I like to keep my fingers busy. I think I'm more calm and focused when I'm doing things with my hands. So eye surgery often delivers instant gratification, more specifically to the surgeon probably than the patient initially, but down pretty quickly the patient also is very pleased with those results. And it also helps that I can jam to some music while I'm in the operating room. Even the patients are able to make requests if they want, and usually I'll allow it, although I'm not a big country fan, and we do have quite a few requests for country music.
I understand you sing.
Sometimes, yeah. Patients will remember, and it's funny that they sometimes find that keeps them at ease, because I guess they realize that their surgeon's pretty comfortable, so things must be running smoothly. I do sing sometimes. Can't say I'm on key all the time. So cataracts, a little bit about cataracts. Most of you probably have heard of them. They obviously slowly steal sight by gradual yellowing and clouding of the natural lens, which sits right behind the iris in our eyeball. Usually this starts in your 50s, but most people do not have the effects of cataracts like blurry vision, glare and halos around lights, especially at night, until you reach your 60s and beyond. So cataract surgery has a profound effect on people's lives, especially for those who might have waited too long to finally have cataract surgery, or for those who have a more rapidly progressing cataract. The improvement in vision that this relatively painless 10-minute procedure restores is wonderful. Shapes, faces, and print generally clear up in a few days or a couple weeks. Colors pop again. Snow suddenly doesn't look like, Alfonso's husky from the Frank Zappa song tinkled all over it. So, it's bright and white again. And glare from lights, especially at night, also is usually eliminated, so people feel safer, especially driving at night. In rural areas, again, many patients have limited access to eye care. So it's not unusual to see more advanced cataracts with people who have poor vision. So being able to restore this demographic's vision is incredibly rewarding. What a change it is to finally see again. Last year, I did over 2,000 cases here, 2,000 cataract surgeries, so that's at least 1,000 people that benefited from cataract surgery. So our team does help a lot of people see better here, and that's obviously very rewarding to me and my whole team.
I have a funny story. I have a friend who went out and bought green towels. She had cataract surgery and found out her towels were blue.
Yeah, that's not uncommon. Yep. And then you also discover that, I have wrinkles, or my hair I thought was like a dusty blonde. Now suddenly it's silver. It's never gray. It's silver.
So you mentioned working in a rural setting. Tell us a little bit more about that.
Yeah, I think it's nice to work in a rural setting. Number one, I'm kind of sick of city life. I liked it as a younger lad, but obviously the hustle and bustle, the traffic, and the crowds, I think almost everybody, as you get a little bit wiser, you tend to dislike that. But anyway, practicing in a rural setting means I often see patients who travel long distances for care. In urban areas, obviously, there are more specialists and resources available, which makes it easier for patients to get timely treatment. The eye may be small, but it's hard to believe there are at least 8 subspecialties within ophthalmology. And let's not forget the invaluable eye care that our optometrists provide medically and through glasses and contacts. Urban areas like Seattle have over 100 ophthalmologists and optometrists, many subspecializing in various parts of the eye, so most people only have to travel a handful of miles to get the eye care they want or need. In SQM, heck, all of Clallam County, we rely on only one ophthalmologist and about a dozen local optometrists to deliver the eye care to this large rural community. I guess I forgot a shout out to my retina colleagues. There's 3 of them that work a couple blocks away from where I am, and thanks for their help. We need them quite frequently for various bad disease in the back of the eye, like diabetic retinopathy or macular degeneration. The rural eye care provider must be able to tackle a wider variety of eye disease, since access to subspecialty care is often far away and difficult to access. So I'm grateful to have such an excellent crew of local optometrists to help me take care of the eyeballs of the Olympic Peninsula. I also have 2 excellent optometrists within my own office that take care of a wide variety of medical eye disease, which then allows me to better focus on the surgical eye needs of the area, which is very nice.
I forgot what I was going to ask you.
That's all right. We can jam out to some more tunes.
So you mentioned some people wait too long for surgery. How do you know you've waited too long? Or if you, for instance, you see an optometrist and they can kind of tell you, gee, it looks like you're starting to develop a cataract. At what point do they make that decision if it's mild and if you've waited too long?
Yeah, I mean, what typically happens with patients is they just simply wait too long, or they don't realize things are going downhill with respect to their vision. It's not uncommon to finally see patients come to us after they fail their vision test when trying to renew their driver's license. While it certainly should trigger them to get their eyes examined, it's better to recognize your vision is fading before you're unsafe on the roads. So the most common symptoms of cataracts are blurry vision, glare, and halos, especially around lights at night. Now, granted, there's a lot of things that can cause those same problems, but when you come in, we can do a full dilated eye exam to allow us to better diagnose what's potentially causing this problem.
What kind of tests do you do to see if someone is like night blind?
Yeah, night blind's a little bit more difficult. We don't test that as frequently, but we obviously do the typical chart that you see the E's at different directions or different letters, just to get an idea of how depressed is the vision, how far down are they going. There's a lot of other aspects that we don't routinely check, like contrast and color vision, but those are different tests that we can do to better gauge whether night vision is going down. I think the night vision issues is not as difficult, or is not the key point with cataracts. What one does get with the cataracts is, it's not that they're night blind, but the glare from oncoming lights makes them kind of night blind. The glare just distracts the vision and deteriorates the vision. So the way we do check that actually is when they're checking out the vision chart, we'll often shine a light in their eyes. Usually it's pretty bright, so that we obviously can make the effect of the glare that typically is caused by the cataract. So that's how we test for.
And you can see that when you.
We can see the cataract after we dilate the eye and then look inside the eye. So the lens in our eye is about the size and shape of a plain chocolate M&M, and it sits right behind the iris. Obviously, when we're young, it's very clear, and in our 40s. In our 50s is when it starts to gradually yellow, and you can see this when you're looking through the dilated pupil. So then that clear M&M turns more into a golden nugget, if you will. It becomes more firm, and it becomes more yellow and cloudy as time goes by after age 50.
So how does being a rural ophthalmologist differ from practicing in an urban environment?
Well, the unique challenges in your rural communities are, again, it's more difficult to get access to care. One of the challenges I have in rural community care is I have to realize how good an ophthalmologist I am and what my limitations are. So I do think I'm a pretty darn good ophthalmologist, and my facility, Northwest Eye Surgeons, is well equipped with modern technology. But it's also important, like I said, to know when you need help managing more complex cases. Again, in Seattle, you could throw a rock and hit the next appropriate subspecialist, but in SQM, we have to develop good communication with our remote specialists and coordinate access to the care when needed. One of the best qualities, I think, of a physician is to know your limits and know to have the humility to refer to another person when needed. Another challenge, I think, in the rural setting is that most people do not seek care until their vision fades to a degree that makes them unsafe to drive or perform their normal daily activities. So with a limited number of eye care providers in a vast rural area, patients may be unable to get timely appointments. And then the longer the cataract exists, the more severely it degrades one's vision, the more dense the lens becomes, making it more difficult to remove by cataract surgery. Because when I do cataract surgery, I just have this vibrating vacuum, it's called phacoemulsification, that just breaks the cataract in small pieces and it sucks it out. You know, the lens is more like Jell-O when we're young, but as we get older, it gets more firm, more like maybe a gummy bear, and then more even firmer yet. So you need more energy to suck that cataract out if you wait longer and longer.
I did not know that. Mm-hmm. Okay. And we had a caller that wanted to know if you could talk a little bit about RLE.
Yeah. So RLE is abbreviation for refractive lens exchange. Some people call it dysfunctional lens exchange, but basically this is a procedure where I go in and take out the lens before it actually has a cataract. So these are typically people in their 20s, 30s, and 40s, mostly in their 40s, where they want to get out of glasses, especially in their 40s, because that's the time of life when most of our lenses are unable to zoom in on things. So when you're in your 20s and 30s, you're able to see everything from distance to near through one prescription or no prescription if you're fortunate enough to not require glasses to see well. But again, in our 40s, this thing called presbyopia occurs, and this is where we're unable to zoom in up close on what we used to see. So that's when most people wind up needing readers or bifocals to see their best at all these different distances. So there's a group of people who are willing to pay. This is not a free procedure. I mean, we're taking out a completely normal lens that just has gotten a little bit aged and unable to zoom in on stuff. But anyway, we go into the eye, remove the natural lens, and put in a lens that allows a wider range of vision, a multifocal lens. And that's what a refractive lens exchange is. It's essentially the same procedure as cataract surgery, except it's prior to cataract formation.
So what if someone gets RLE and then they find that they have cataracts? Then what happens?
Well, the fortunate part of RLE, I suppose, is you never will get a cataract because I've removed the natural lens before it has aged and become yellow and cloudy. So it forgoes the need for cataract surgery early. So it's, in a way, it's kind of nice to maybe say, look, I'm just going to get RLE in my 40s or 50s because then I don't have to worry about cataracts down the road. And especially in those who require glasses to see their best anyway, this allows them to have a longer life potentially without the need for any glasses. So there is advantages to considering RLE in your 40s and 50s.
Well, let's talk a little bit about if you can use Medicare for correctives for cataract surgery. What type of lens does Medicare pay for?
Yeah, so we can talk about that. So Medicare, most insurance plans are more than happy to pay for cataract surgery for the full function of removing the cloudy lens that's distorting one's vision. Insurance plans, however, do not care if you need glasses or not after surgery. So all cataract surgery involves going into the eye and taking the cloudy lens out and then implanting an artificial clear intraocular lens, or IOL, intraocular lens. So with what insurance will cover with respect to the intraocular lens is the standard, quote-unquote, IOL. A standard intraocular lens is just a monofocal lens that's spherical in that it does not take care of any astigmatism. So people who get standard cataract surgery often do get better vision, but usually they will require some sort of prescription to see their best because almost everybody has astigmatism. And what is astigmatism, you'd like to ask, I'm sure. Well, astigmatism is when the cornea which is, of course, the clear hemispherical window to the eye right in the front. It's more like a football cut in half rather than a basketball cut in half. So a basketball cut in half has no astigmatism because it's the same curvature every axis that light enters into the eye. However, obviously a football cut in half, one curve of the football is steeper than the other curve of the football. So that's what astigmatism essentially is, and anyone who has astigmatism needs some sort of prescription to fix that. So a standard intraocular lens, because it's spherical and monofocal, would not correct that. So those who want to perhaps have freedom from glasses have to opt for, these specialty advanced technology lenses.
What common misconception do people have about cataracts and their treatment?
Well, most people feel cataracts are just a natural part of aging and cannot be treated. Although I don't know how many in this area think that. I mean, we do have an older population here, and I think most folks realize there is surgical options to fix this because they've had friends who had surgery in the past. But a lot of people still have fear for pain or the scary complications that exist. Will I go blind? Oh, my friend had a retinal detachment after cataract surgery. While these risks are true and potential, they're extremely low. Cataract surgery has been around for centuries, and it was certainly more difficult in the past, but over the past 3 decades, it's become one of the safest and most effective surgeries one can have. Certainly nothing in life has zero risk, as I say to all my patients, or has 100% guaranteed results. But in my hands, cataract surgery typically takes about 7 to 12 minutes. I often will talk my patient through the surgery, informing them of every step during the case, or at least warn them of those steps that might be uncomfortable. And this seems to ease my patients. And also, like I said, like you actually heard apparently, I do sing sometimes during the procedure because we often have music. Well, we always have music playing in the background. And it does seem like even if they don't want to know anything about the case, again, that calming, screechy voice of mine seems to put people at ease, even if I am off key.
Dr. Psolka, what advances in cataract surgery have you found most beneficial for your patients?
Well, yeah, I love ophthalmology because it is fast-paced and ever-changing, especially when it comes to technology. Centuries ago, we used to simply push the cataract to the back of the eye. That was called couching. Probably not very effective to have clear vision afterwards, but that's what was done. And it wasn't even until the 1970s or 1980s that it was routine to put an intraocular lens in the eye after removing the cataract through a large wound and bypass the need for these thick Coke bottle glasses that you might still see people wearing nowadays. So over the past 30 years, incisions have gotten a lot smaller. Equipment used to evaluate and remove the cataracts has improved dramatically. Biometers are more precise at measuring the length of the eye and the curvature of the cornea, which allows me to better select which intraocular lens, or IOL, will deliver the most predictable and satisfying outcome. Many people see better after cataract surgery without glasses, even better than they did without glasses before surgery. So hopefully that made sense. I know it's kind of weird. So again, people who needed glasses to see their best, without glasses, they probably don't see well. After cataract surgery, we often make them see better than they ever did without glasses before surgery. I don't know if that made sense, but hopefully it did. Anyway.
Your vision's better.
Yeah, great. Your vision's better after cataract surgery in general, and hopefully we can get you out of glasses. The process, or the tool that we use to actually remove the cataract is called a phacoemulsifier. It's just a fancy word that means using ultrasonic vibrations to break the cataract into tiny pieces and then vacuum them out. So it's kind of a combination thing of an object that vibrates and sucks. So kind of like the suck cut from Wayne's World for, haircut. Anyway, weird aside. So these devices, of course, have become more and more efficient such that less energy is needed to break the cataract into small pieces, and it allows for safer surgery and quicker visual recovery. Many people think lasers do cataract surgery now, but that's not entirely true. Yeah, we do have lasers that help break the bag and make the cataract broken into small cubes, but we still need to go into the eye as a surgeon and then remove these fragments with other tools. So yeah, there are lasers that assist in cataract surgery, but they don't do the full surgery. One of the biggest advancements in cataract surgery since Y2K has been the evolution of advanced technology, IOLs. These lenses allow us to deliver spectacle freedom after cataract surgery. Insurance companies see this as a luxury, but patients do have the opportunity to throw away their glasses for most or all activities if they choose to have an advanced technology lens implanted during cataract surgery. There's a variety of different types of these advanced technology lenses. Toric lenses to fix astigmatism. Then there's multifocal lenses accommodating intraocular lenses, extended depth of focus lenses, and small aperture IOLs, which each have promise to spectacle freedom for those who wish it. And again, insurance companies don't care if you need your glasses after cataract surgery. So these advanced technology lenses do require a fee to be paid to the surgical facility, because these lenses are also a lot more expensive to procure and create.
Well, give our listeners just a little indication of what kind of cost are we talking about?
Yeah, so at our facility, we generally charge about $3,000 to $4,000 extra per eye for these advanced technology lenses.
For the fancy lens?
Correct. And then again, the hope or promise is that you wouldn't need glasses for most, i.e., distance usually, or all things if you choose to go with the multifocal lens. So again, the more freedom from glasses will cost you more, about $3,000 for our Vision Correction 1 plan, which is for distance vision, and then about $3,800 for Vision Correction 2, which is our multifocal plan, so that you have vision from near to far.
We had another question from a listener. She wants to know if you've already had cataract surgery, does RLE surgery make sense?
Not really. I mean, one could consider exchanging a lens for a more advanced technology lens, but that procedure is a little bit more high risk than performing the original cataract surgery. It's essentially the same procedure. You have to go in the eye, take something out, and put something new in. However, these artificial lenses, they're usually made of silicone or acrylic plastics, kind of. They're more difficult to remove because they're more firm. And especially if the cataract surgery was 6, 12, or years before, those lenses tend to get scarred in pretty well, and they're very difficult to remove. So when I do have to remove an intraocular lens, an artificial lens, I am happier to do it within 3 to 6 months of implantation, because then it hasn't had the chance to scar in as sticky. It's easier to remove that way. You hinted at, what insurance will cover and what insurance won't for cataract surgery. So, I mean, I can get a little bit more into that if you want. And I think the patients out there who might need cataract surgery might appreciate this. So, if I may.
Yes.
Let's go. So, yeah, there's a variety of options when you have cataract surgery nowadays. So, yeah, I mean, even in the 80s and 90s, when patients would come to me with a cataract and they needed surgery, the conversation was pretty cut and dry and pretty short. Okay, you got a cloudy lens in your eye. I'm going to go in the eye, and hopefully in 15 or 20 minutes, instead of 10 minutes or 5 minutes nowadays, I'll go in there, take out the cloudy lens, and put a new lens in. And in about a month, you go get new prescription for glasses. Well, again, these advanced technology lenses have changed the game. They are true game changers. So we do have toric lenses to take care of astigmatism, which can better improve your distance vision. And then we have multifocal lenses that can give you that range of vision. So I'll talk a little bit more about how we do that here. The toric lenses are used to put in the eye at a certain axis depending on where one's astigmatism is. Again, you have 360 degrees in a circle. The astigmatism is typically on one of those axes between 0 and 360 degrees, or really 0 and 180, because it's 180 degree meridian. But anyway, we put these lenses in the eye, eliminate the astigmatism, and allow people to have clear distance vision. So then they can play golf, they can bird watch, they can drive without glasses. And then when they're reading or working on a computer, they just need to go get simple over-the-counter reading glasses. And they're only $1.25 at Dollar Tree, but you can obviously go and get Pradas if you're a stylish person. At Northwest Eye Surgeons, we call this particular plan the Vision Correction 1, and we happen to charge $3,000 per eye for this option if you want clarity at distance and don't mind the need for reading glasses. The next step up, again, is the multifocal lens, which allows us to give you freedom of glasses for all tasks: near tasks, intermediate or computer distance tasks, and far tasks. This option we call Vision Correction 2 at Northwest Eye Surgeons, and this option is about $38.50 per eye. So during cataract surgery, I will put this multifocal lens or extended depth of focus lens in your eye, and then you will have clarity when you're reading books, when you're looking at your computers, when you're driving. You'll enjoy watching television as well, because again, you have that full range of vision.
Well, here's a question. Suppose you won the lottery and you had cataract surgery.
Yep.
You got the regular, step one.
Yeah.
And now you've decided that you really do want to be able to see at all distances, close and mid and far.
Yep.
What would it take? I mean, you just said that you don't like to take out a lens that's been in for a while. How long would that be? Like a year? Or
yeah, I mean, typically, even 6 months, it gets a little bit more risky. The artificial lens does scar in place fairly quickly, and everybody has different healing or scarring potential. I recently had one patient who I had to do surgery on, or change the lens that was implanted. I think it was within even 3 months. And I was surprised how much scarring was holding that lens in place.
Okay.
I mean, several years ago was the first time I ever had to do a lens exchange, an artificial lens exchange. This was a patient who had the lens for 2 years, and I was always worried to do anything like this because of the amount of scarring that is typically present after 3 to 6 months. I was baffled. I don't know why, but it was a very simple procedure on that particular day for this person who had a lens for 2 years. So it does vary, but typically, obviously, the longer an artificial lens is in the eye, the more risky, the more stuck down and scarred in place that intraocular lens is.
What if you've had cataract surgery and you have a detached retina?
Yeah, well, that's why I love our friends right up the road. A detached retina obviously needs attention. We don't have all the tools necessary to fix those sort of things. Oftentimes, they're mild retinal detachments that are way in the periphery and are barely affecting even their peripheral vision. But we still would send that to the retina surgeon, where they would probably do a little laser on the retina to scar the edge of the detachment so it can't progress any farther. And then, of course, if there's a more severe retinal detachment, we would send it to our friends, our retina colleagues just up the road, for them to potentially need to do surgery, whether that's a belt or a scleral buckle around the eye, or put gas in the eye to push the detachment back to the choroid. They have their magical techniques, and I value their assistance.
How do you know when you're ready for cataract surgery?
Yeah, I think... Again, typically cataracts don't start forming until we're in our 50s. And the symptoms that people may notice or they neglect is the gradual blurring of vision. And the other main symptom is glare and halos around lights, especially at night. It's very slowly progressive typically. Just like if you've ever been a parent, when you have your child, they grow right before your eyes, but you don't notice the big jump that they make in height. It's when your parents, their grandparents come by and they say, "My, how Johnny has grown." Well, that's again, they're looking at them at age 1 and then potentially at age 2, whereas you're seeing them every day. You don't see the change as much. Well, that's kind of what cataracts do. They slowly steal sight, if you will. It's pretty uncommon, especially in first world countries like ours, where it steals sight completely because it is so slowly progressive. But yes, there's a gradual blurring of vision. Colors you may notice are not as vibrant, but again, because this is so slow, you don't appreciate this decline. Yeah. And that's why, again, I can't tell you how many times I've had it where typically we get referrals because they can't get their license from the DMV. They said I can't see well enough. Well, it didn't just suddenly happen. I guarantee you that. Your vision has been declining for years or decades, and those are the symptoms, though. It's very simple. It's blurring of vision, not that there couldn't be a million other sources for that, and glare and halos around lights at night. Those are the two more common problems. So people can't read as well. They aren't seeing the bottom line on the television, the news ticker, or they're blinded by lights when they're driving at night. These are the big symptoms that you should draw your attention to get an eye exam and potentially need cataract surgery.
So when you go to the optometrist,
Yep.
who is giving you the eye exam to see
Yep.
if you need glasses or not, and they say to you, "Gee, you're starting to get a cataract."
Yep.
At that point, when the optometrist is just starting to see the cataract, how long do you wait before? I know that the optometrist has to give you they're the ones that have to say, now it's time to see the ophthalmologist, right?
Yeah.
You have to get a referral.
Correct. Yeah, the optometrists will keep an eye on your vision, and again, they will probably discover the cataract before you notice the symptoms. And then usually when the patient hears it, well, everybody's a little different, but some people will focus on that, and then they may be the ones who get cataract surgery earlier because they say, wow, I do notice this change in vision. Others may ignore the subtle changes in vision, but that's to each his own. But yeah, the optometrists are generally the ones who discover the cataract first. And again, usually the vision isn't degraded too much when it initially occurs. So we generally will see those patients once a year, maybe more frequently if they have other issues, until their vision declines enough that that the patient is unsatisfied with their daily activities. They can't read, they're upset with that, or they can't see their golf ball flying in the distance. And those would be reasons to finally see or suggest, hey, I'd benefit from cataract surgery. So.
Well, share with our listeners your journey to becoming an ophthalmologist and what led you to practice here on the Olympic Peninsula.
Yeah, that's a pretty long one for sure. It did take a while for me to finally get into ophthalmology and dedicate my life to these two tiny ping pongs on our face. I'm a very visual person, and you guys might notice I'm a little bit on the colorful side. So I am very stimulated by the variety of shapes and colors that I see in my daily life and in my travels. So I cherish the gift of sight. I grew up in a small town in central Pennsylvania where I got to enjoy the varying changes of skies and landscapes with the weather and the seasons, because Pennsylvania has 4 true seasons as well. We do have some blasting colors in the fall foliage. My younger brother and I were lucky to have pretty supportive parents. They may have been a little bit overprotective, but we appreciated their interest and involvement in our academic and athletic lives. We were a very athletic family, so we played tons of sports growing up, eventually focusing on football and track in our high school and college days. When we were young, most of us are lost in our futures, trying to find the right path. I mean, even I, in my senior year of high school, was still dreaming of playing in the NFL. Eventually, though, I realized that a 5'11", 175-pound running back that takes more than 4.6 seconds to run the 40 yards is not going to go to the NFL. My father probably was my greatest influencer and advisor. He was an intelligent man. He was an architect. And I did realize that my brain thought more in objective patterns than subjective patterns. It was more mathematical, more scientific than linguistically awesome, as you can tell. I have trouble finding words sometimes. So I decided to pursue engineering or architecture, just like my father. He also was in the Air Force for a few years. That's how he met my mother in Germany. So I thought even of a military career, and my parents kind of pushed it because it's cheaper education. The military would pay for college, or when you go to the academies, it's free. So I thought maybe a fighter pilot. I had that perfect 2015 vision, and I loved speed and the idea of flying. Ultimately, I got accepted to the Air Force Academy, but turned them down. I'll never forget it because I was on the phone with Alan Spector. I think he was House of Representatives for Pennsylvania. And I said, sorry, I'm going to go to Johns Hopkins. So yeah, I went to Baltimore, just south of the Mason-Dixon line, and chose to study civil engineering at Johns Hopkins in Baltimore, Maryland. Now, clearly, you guys probably can't see where or why did I finally get into medicine. I'm going to do civil engineering. Well, my answers are not as glamorous or wholesome as you might expect. Sure, I wanted to help people. Doesn't every doctor? But life experiences forged my path. My athletic career and those pesky injuries associated with these athletics piqued my interest in anatomy, physical therapy, and orthopedics, especially after I suffered a meniscal tear in my knee during track in my freshman year of high school. I was really bummed about that knee injury because it prevented me from lettering in my freshman year. It would have been a 4-year letter winner, and I was pretty proud of my athletic achievements. I had that chunk of meniscus in a test tube on my desk for years after its surgical repair. Anyway, my father, he had a history of having been shot in the eye by a BB gun when he was a kid, and he dealt with distorted vision for years, even though he was an excellent shooter when we would go duck, pheasant, or dove hunting in the fields of Pennsylvania. That incident, combined with my brother's lazy eye history, kind of kindled my ophthalmology aspirations. So in addition to all these wonderful math and physics classes I took during civil engineering at Hopkins, I also took the pre-med requirements so that I could keep my options open. Fortunately, I did finally receive that ROTC scholarship to pay for the school and keep another door open, one which, of course, would eventually turn into a 25-year Army career. The rigorous workload of physics, math, biology, optics, and chemistry, along with my continued participation in football and track, kept my interest in orthopedics and ophthalmology. Now, these are obviously two very different specialties, but I trusted medical school would help me better define my path. So when I was finally accepted to medical school, which was the military medical school called Uniformed Services near Washington, D.C., I finally got to get more involved in the various specialties and eventually just said, hey, eyeballs I'm in love with, let's do it. I mean, sometimes quality of life matters. I did play rugby while I was in medical school, and all those jocks were even smarter than me. I was intimidated, and they all wanted to do ortho. So I guess it was twofold why I decided on ophthalmology. One, these guys are smarter than me, and they play rugby with me. Two, I do like a little bit of quality of life. It's very rare that I get called in the middle of the night for an eye emergency, but people break their bones and dislocate their joints all the time. So there's good quality of life in ophthalmology as well. So that's kind of how I got into ophthalmology.
What is it like living and working on the Olympic Peninsula, and how does the environment influence your practice?
Well, it is a beautiful place, this part of the world, no doubt about it. I love that it has 4 seasons. I'm glad we finally got snow to prove the 4th season a little bit more for me. I mean, we can see it in the mountains all the time. That's nice. It's a beautiful area. It offers a wide range of outdoor activities. And I like to do a bunch of different things outside. So this area, of course, is a slightly older demographic, but I think it's a very active population as well, due to the pleasant climate and the varied geography. So people want to be outside and they want to stay active. They want to explore. So I find that vision is the key sense through which to appreciate and experience the mountain and the sea. This active population demands freedom and pushes me to stay on the cutting edge of technology so that I can deliver the best quality of vision and their best quality of life. So those are the big things in this area, I think.
I believe that I waited very, very long after being told that I had cataracts. Mm-hmm. And they kept saying to me, it's not time yet, it's not time yet. And it got to the point where I literally could not drive at night at all. And so finally I just went back and they said, well, I think, okay, we can do it. So talk a little bit about that. Do you have to wait?
Yeah.
When it gets to the point where it's just not workable anymore?
Yeah. Certainly, if you're bothered by symptoms, and we see nothing else on eye exam other than a cataract, then cataract surgery is warranted. Now, whether it's going to come out of your pocket or if insurance is going to cover it, that's a decision that each insurer makes according to whatever criteria they have. Some insurance companies will not pay for your cataract surgery unless your vision is 20/50 or worse. Most of them, your vision has to be 20/40 or worse. And a lot of insurance plans realize that vision may not be that degraded that much, but with glare testing, where we shine a light in the eye when you're trying to read that vision chart, if your vision drops several lines to 20/40, 20/60, 2100 or worse, that's usually enough to warrant cataract surgery where insurance will cover the costs. If, however, insurance won't cover the costs, and you're bothered by symptoms of blurry vision or glare at night, can't drive at night because of those lights, you could still get cataract surgery, but is it going to be paid by insurance, or are you going to have to pay for it? And obviously a lot of people are unwilling to pay for it unless insurance covers it. And I don't have the number on the back of my hand, how much does cataract surgery cost if you're paying out of pocket? Because certainly we do take care of people who don't have insurance as well, and they wind up having to get the funds to pay for cataract surgery. I don't even know if I want to guess. I'm going to say $2,000 to $3,000 per eye to cover the cost of non-insured cataract surgery.
Okay.
Yeah.
Well, you have a poem that you received from one of your patients, and you wanted to read that for us. Yeah,
I mean, before I get into it, I want to shout out to my crew.
Yay.
Yeah, if I don't get choked up. I mean, I I cannot express how lucky I'm very lucky to work with 30 amazing women. It is a bit of estrogen, so sometimes it gets a little rough. But yeah, I work with a great crew at Northwest Eye Surgeons here in SQM. Oddly enough, all 30 of the people are women. So I'm probably a little odd man out for sure. But anyway, they're tremendous at what they do. Everyone from the front desk to the technicians that work up my patients, to the gals that give me all the tools so I can do my work, and to the nurses who make sure my patients are stable, and of course there's Barb who runs the whole show. You guys are awesome. And we get a lot of compliments all the time. This just happened to come in yesterday. So I did surgery on a patient this week, and I guess she was pretty amazed by the, again, immediate gratification, why I love being a surgeon. So she made this card, and let me read this Dr. Seussian poem for you. So she writes, "In the land of the blur and haze, you swooped in, a hero to amaze. With tools and tricks and magical flicks, you banished those cataract pricks. Nurse and staff, all in on the act, made me feel like a superstar, that's a fact. From squinting and guessing to finally confessing, my vision was a mess, now it's impressing. No more mistaking my cat for a hat, or thinking a lamppost was where I sat. You've given me sight, I'm back in the game, seeing things clearly, each face, each name. Here's a shout out to the medical crew for fixing my vision and making it new. With laughter and jokes and a grateful grin, thanks for the journey from start to end."
Oh, that's very sweet. So tell us, where is your office?
Yes, our office, Northwest Eye Surgeons in SQM. We're at 795 North 5th Avenue. That's where we are. And you can call us to schedule an appointment. Our number is 1-800-826-4631. You can also visit our website if you like. That's nweyes.com, NW standing for Northwest. So again, nweyes.com. And again, our phone number is 1-800-826-4631.
And so it's kind of like one-stop shopping, right? You can go in and get an optometrist.
Yep.
To check out your vision.
Correct.
And then if cataract surgery is necessary, you're right there.
Correct. The one thing that makes us a little different than most optometry / offices, we are ophthalmology optometry group. We don't, however, do glasses and contact lenses. So we rely, and we're very thankful of the local optometrists that do those functions.
Okay, this has been the Working on Wellness Radio Forum. Working on Wellness is a health education program of the Dungeness Valley Health and Wellness Clinic, SQM's free clinic. The clinic provides basic urgent care and chronic health care services to uninsured community members. Their work is supported by more than 70 volunteers, including physicians and other professional health care providers, as well as lay persons in the private and public donations from the SQM community and beyond. And so their supporters are Jamestown Family Health Clinic, KSQM, of course, and the Olympic Medical Center and Accusure Insurance. Basic Urgent Care Clinic is open to patients on Monday and Thursday evenings, beginning at 5 p.m. Individuals interested in supporting the clinic may call 360-682-0218. And I want to thank you very much for coming in. This was your first time with us, and I hope you'll do it again.
Yeah, I hope so. This was fun.
Very good.